it was luckily got up in the phaco wound. So all's well ends well, I was able to finally take it and then complete the implantation. So the idea of MAGS is now moving in glaucoma again. So this is the simulator that we have made. On the left hand side you can see the view through the portable simulator. On the right hand side, from the outside it looks as if there is nothing, but this is the next gen simulator module that I have made. And once this stent is placed correctly in the clavicular meshwork, you can see a green lighting there. So that's how the coding of this particular simulation is done. And this really helps in hand-eye coordination into the MIGS armamentarium. So this was got from one of the inspiration from one of my surgeries, and it's a patent protected innovation. To analyze the wet lab training with a surgical simulator training was the idea to take forward, and when various post-graduation institutes on road shops, this was done through 30 glaucoma fellows in a study period of 3 months, and these were some of the questions that helped us refine it. Was it adequately prepared for real surgical procedures after completing a simulative training? So that was one of the questions that we took the answers after a focus group discussion. That the simulator helped in hand-eye coordination, which was again very satisfying. What was the rate of satisfaction level in simulative module, and adequate visual feedback. So there was this haptic sensation that was implanted where it gives you the pseudo sensation or the feel of touch when this was being done. And again, the feedback to improve the surgical skill through the haptic touch, which was more of a sensation in the ear, which was also made into it. What was the amount of surgical confidence that was there? We used a Likert scale, which is the basic standard scale that you use to assess these. And was it really helpful in reducing the likelihood of making mistakes in the MIGS procedures? And what would be the rating that you will give to accessibility of the simulator was another question. And was the environment a safe environment? And would you recommend this for your neophytes who are going into mix? And was the graphics and structures very real? And along with that, the wet lab was also compared, where a cross-sectional comparative study with a questionnaire through Google Forms was sent, with all these components of the questionnaire comprising of different percentages, realistic training and learning, surgical planning and guidance, safety and recommendation. And these were the feedback again in Likert scale, which was especially the satisfaction levels with the simulator. Without the simulator, that is, you do have some certain non-simulative modules that you do for MIGS along with the simuli eye, but that's not possible in a human or in a cadaveric eye. And again, a Likert scale of satisfied, neutral and dissatisfied, and a p-value with the PAR-T test was obtained. So definitely it served as a good module to start your MIGS journey. And you can see the 97.4% compared to the 89.44 without it. It's not a big difference, but it definitely is another edge that gives you over medical virtual reality or augmented reality that it is fondly known of, and it's easily accessible. So this IMG Holo is there as an application. If you have an Oculus or if you have a HoloLens with you, you guys can download it. And there is also a mobile phone description of the same named as IMG Max for iPhone users, and it's a very cost-effective one. We have not charged it, no financial disclosure again. So according to our knowledge, there is no application till date which gives you real-time high-resolution augmented reality images and photoreal visuals for interactive 3D simulations, where especially for MIGS. We have many simulations for cataracts, but again this IMG Holo is free of cost. It's very cost-effective and accessible, and I think this is a science fiction, but it is no more a science fiction, is what I fondly say. It's a science-based reality. And again, G1s are now out of order, but again last year when I presented this, I'm just presenting the same. So this was again a G1 case of mine. You can see that when I took it, the simulator the stent was not there, and I had to now take the stent, approach, align, grasp. So these are all very microscopic, in a very fine fingerprint kind of stents, right? You can see the polarity of the stent, how it's trying to go away. So it really helps you, this gamified learning really helps you in 10 seconds. So for hand-eye coordination, and that's what is all about my talk. So thank you once again to the scientific committee for giving me this opportunity.
So good, Prasanna. This was presented last time also, and it was very nicely presented. So now we start with a pre-paper session in glaucoma. Each presenter is around 5 minutes. So first presenter is Vijayalakshmi. Is she around?
Yes, sir.
Yeah, please.
Good evening, everyone. I am Dr. Vijayalakshmi. So I will be presenting a paper on outcomes of KDB goniotomy versus NPDS paper in patients with advanced glaucoma. The goal of any glaucoma surgery is mainly to preserve the existing vision In patients with advanced glaucoma, one will be reluctant to perform any invasive glaucoma surgery for the fear of macular snuffle or whitecoat phenomenon, which is reported to occur in 0 to 13.6% of these patients. Previous studies have clearly shown NPDS to be a safer option in such high-risk eyes. However, the safety and efficacy of mix in such advanced glaucomatous eyes have not been explored well. Hence, our aim was to compare the 1-year safety and efficacy of combined KDB phaco versus NPDS phaco in patients with advanced glaucoma. Ours was a retrospective comparative study. We included 114 patients. We basically included advanced glaucoma with significant cataract with open angles. We excluded eyes who underwent standard NPDS or patients with unreliable visual field. All patients underwent a standard pre-op glaucoma evaluation. Also, they received a standard post-op deck care, which included antibiotic steroid eye drops and cycloplegics wherever needed. Post-op maneuvers like LGP and blood needling, they were not considered as failures, they were considered as blood augmentation procedures. And post-op visits included 6 visits until 1 year post-operatively. We collected all the clinical parameters of the patients, including the visual fields, intra and post-op complications. If you look at the demographic characteristics of a study participants, Group A included patients who underwent phaco KDB. About 49 eyes were included in this group, and Group B included patients who underwent NPDS phaco. About 65 eyes were included in this group, and almost demographic and clinical parameters are almost similar between the groups, except for HFA mean deviation and pre-op AGM. So if you could clearly notice, the HFA mean deviation was slightly worse in patients who underwent NPDS phaco. Correspondingly, the AGM numbers are also quite high. If you look at the primary outcome measures, which was based on the BCVA and visual field mean deviation, we could clearly see there was an improvement in mean logMAR BCVA from the baseline value at all post-op visits in both the groups until 1 year. Similarly, there was a stabilization of HFA mean deviation values in both the groups until 1 year post-operatively. If we calculate the success outcomes used criteria 1, we could see Group B participants had 93.9% success and Group B participants had 98.5% success. If you look at the secondary outcomes, which was based on intraocular pressure reduction and decreasing AGM number, so IOP curve is showing a decreasing trend. However, it was only insignificant IOP decrease from the baseline value at all post-op visits until 1 year in both the groups. Likewise, the AGM number also, it was showing a decreasing trend. However, the values were significant from the baseline value in both the groups. As I mentioned earlier, pre-operative AGM number was quite high in NPDS phaco, and the same trend was followed at all post-op visits until 1 year. So if the success outcomes was calculated using criteria 2, we could clearly see patients who underwent phaco KDB, they did not, about 50% of the patients did not require any AGM at 1 year. Similarly, the qualifying success was better in patients who underwent NPDS phaco. However, we do encounter few post-op complications. They were only minimal. The most common being hyphema. About 12 patients had a hyphema. The patients in Group A. Almost all patients required spontaneously. Only 2 patients required AC wash for the hyphema, and few patients in both the groups required additional glaucoma surgical interventions for IOP control. Our study results between KDB phaco and NPDS phaco have clearly shown similar IOP reduction in both the groups with stable post-op visual acuity and central field. And KDB phaco participants, they acquired a greater reduction number of AGM post-operatively. About 50% of the patients in phaco KDB, they required no AGM at all until 1 year. Fortunately, we did not encounter any major vision-threatening complication in both the groups. Only very few patients required additional glaucoma surgical interventions. So if you look into this meta-analysis paper, which compared the efficacy of phaco KDB versus KDB alone, so this participants in phaco KDB, they achieved 22.74% IOP reduction than standard phaco group with a significant reduction in AGM number also. Having said that blood dependent procedures causes more IOP control, our study have clearly shown KDB phaco also produces similar IOP reduction in patients with advanced glaucoma. Hence, KDB phaco could be safely considered in patients with advanced glaucoma. The major strength of the study include us for the first study to compare the head-on comparison between NPDS phaco versus KDB phaco, and also we have explored the efficacy of KDB phaco in advanced glaucoma. Similarly, we explored the efficacy of MMC augmented NPDS phaco.
Thank you.
Yes, thank you, sir.
Vijayalakshmi, you mentioned LGP. What is LGP?
Sir, laser goniopuncture. This will be done after 6 weeks in patients undergoing NPDS phaco if we feel we have not achieved the adequate thickness of the trabecular dispense window.
The hyderma what you had, you took for the knee surgery.
Two
You
patients.
watched 2 patients. After how many days did you take the patient?
So we waited for 1 week, but however the IOP was persistently high. We tried to control the topical and systemic aqueous suppressants along with cycloplegic
Was the patient on anticoagulants?
No, sir. No, the patient are not on any anticoagulants.
Thank you.
Probably they were the participants with pseudo-explosion glaucoma, sir, the 2 patients.
Thank you.
Thank you, sir.
So next presenter, Artis Hashikam.
In my study, I have included consecutive adult primary glaucoma patients who underwent uncomplicated phacoemulsification surgery with 40 to 80 years age patient with POAG and PACG with their glaucoma medication on to target IOP. Excluded patients were secondary glaucoma, glaucoma suspect, any filtration surgery or any complicated surgery were excluded. A retrospective study of 100 patients were done with who completed follow-up of 3 months. Informed consent was taken, detailed history was taken, pre-operative and post-operative examination was done. Here the operative eye post-operatively given prednisolone 1% eye drop 6 times a day for 7 days for 6 weeks with along with antibiotic, and all the glaucoma medications were continued pre-operatively in both the eyes. Post-operative IOP measurement was done on day 1, 7, 1 month and 3 months. Here POAG patients were 62% compared to 37% of PACG patients. Here we can see the IOP change. Mean pre-operative IOP was 14. On day 1 it increased to 16. On day 7 it became 17 millimeters. After 1 month it became 18 millimeters, and after 3 months it became 19 millimeters of mercury. So here we can see after the end of 3 months there was significant increase of 4.8 millimeters of mercury in the mean IOP pressures. Here 52% of patients had IOP increase of more than 4 millimeters by 3 months. Here we can see progressively increasing pressures by 3 months. More than 8 millimeters increase in patient by 3 months has been seen in 9.71% patients. Here we can see the correlation of IOP change with age. Maximum steroid response was around 61 to 7 years. Even in Mohan Kumar et al., the age group was 51 to 60 years. So if we compare our age group, 66% of patients with age group 41 to 50 years showed a more than 4 millimeter rise in IOP by 3 months, followed by 54% in 61 to 70 years of patient. More than 4 millimeter change in IOP with diagnosis. So 54% of POAG patient and 48% of PACG patient showed more than 4 millimeter rise. Here 82% of patients have moderate glaucoma showed a rise in IOP by more than 4 millimeters compared to mild and severe glaucoma. 53% were males and 51% were females. So here discussion. The steroid response is seen when the IOP goes above 21 or 24 millimeters of mercury or greater than 5 to 10. Here 30% of patients were moderate responders, while 5% were more than 16 millimeters of mercury are considered high responders in normal population. But in glaucomatous population, those with glaucoma have an increased risk of steroid response. In Becker's and Mills study, the mean IOP elevation was 17 millimeters compared to normal, which was just 4 millimeter. Upon cessation of the steroid, the IOP normalizes within 1 to 4 weeks. In one study, Boykin et al., fellow eyes after glaucoma, 8.4% of patients with glaucoma that are more than 50% above the baseline IOP. So IOP is a risk factor for glaucoma propagation. 3 are the main risk factors: mean IOP, fluctuation on intervisit more than 3 millimeters, and diurnal fluctuation. Even 2.6 millimeters plus or minus 1.4 can lead to progression. Lee et al., short-term fluctuation can also lead to progression in glaucomatous eye. Matchell and Kim et al. Were showing. Here that we can see in the graph the progressing eye has higher IOPs. So IOP fluctuation of 3 to 4 millimeters are thought to contribute progression in glaucoma. Optic nerve head will lead to irregular IOP fluctuation, will lead to damage and lead to progression. Also, the patient who underwent phacoemulsification surgeries and are given steroids, so we should carefully monitor the fellow eye as well. Thank you.
So what do you think is the mechanism for steroid responders in glaucoma patient?
Steroid mainly in clavicular measure we have glucocorticoid receptors, and steroid mainly dysregulate the glucocorticoid receptors. So it leads to clavicular measure dysfunction, and it leads to the resistance will increase, outflow will decrease, and leads to eventually raise of intraocular pressure.
How many percentage of patients came back to normal?
Sir, 8% showed the response more than 8. Other all developed like less than 4.
Dispensation of therapy
Yes, this is a 50% patient.
So what did it do?
Sir, the other 50% patient were showing more than 4, so they were at high risk of progression. So we added medication. So it's my message to observe the other eye as well, because if you add the medication at perfect time, you will avoid the progression.
Prudent to say that you can set a figure of 3 or 4 millimeters of mercury, because every patient will respond differently. Right? And the other thing is that is there a difference in the effect of IOP fluctuation on patients who have, say, advanced glaucoma and those who have mild glaucoma?
Yes, sir. So if patients are having advanced glaucoma, even 2 millimeters or 2 to 3 millimeter fluctuation will lead to progression. Yes. Yes. So, sir, I have done. So mostly the patient in moderate glaucoma criteria showed a rise, significant rise. So they should be monitored.
So yours was a retrospective observational study. So if you would have to conduct a study, a prospective study, what would you like? What is the weakness of the study?
Ma'am, the weakness was I couldn't monitor the patient like preoperatively in which medication.
So do you think it should be an RCT, it should be compared to the controls as in the IOP in a normal people, in a normal population, how would the IOP trend, and you compare it to the glaucomatous eye rather than only in the glaucomatous eye?
So ma'am, I would like to measure the fluctuation in normal population versus a glaucoma patient, and also the groups, different groups like normal versus glaucoma suspect, normal versus moderate glaucoma.
That would make the study more powerful.
Yes.
And more,
Yes.
you can infer more from the study to the
Yes.
population by that.
Sure.
What surgical intervention would you do for these steroid responded glaucoma? Non-responders?
Sir, if they are non-responders, we'll definitely go for claviculectomy surgery.
With the number of and the figures of IOP is what you should. Will you go for a trap
No,
or
sir.
something?
Within 6 weeks, mostly the patient will, after 4 to 6 weeks, IOP will come to normal.
50% didn't come to normal, you said.
Yes, so
So in
sir,
that 50% you have added medication. Suppose with medications also the IOP is not controlled.
yes.
Then which glaucoma surgery you think is safest instead of responder?
So, claviculectomy is safe. Or we can do the latest NIGS surgeries because they already went through phacoemulsification.
We have a next.
gap combined with phacoemulsification in primary annual closure glaucoma. I have no financial disclosure. Primary annual closure glaucoma is considered more challenging than open annual glaucoma. Trabeculectomy being the standard choice of surgical treatment, often it is associated with various vision-threatening complications. With MIGS, now the management of glaucoma has evolved in open annual glaucoma, but the literature regarding the safety and efficacy of GAD in PACG is limited. Combined phacoemulsification with IOL implantation has shown IOP reduction in up to 72% patients with PACG, but for long-term IOP control, filtration surgery is needed. Combination of MIGS with phaco plus or minus GSL has shown promising outcomes in PACG patients. Peripheral anterior synecdoche is the major hurdle which needs to overcome to perform prior to perform MIGS in PACG, which can be done by the cyclodialysis spatula. The persisting ITC contact and progressive pass damages the trabecular meshwork and stems canal, thereby providing a good rationale for GAD in PACG. The aim of the study was to assess the outcome of GAD combined with phacoemulsification in PACG patients. It was a prospective study included 84 eyes and for a duration of 6 months. PACG was diagnosed with a pre-treatment of IOP greater than or equal to 21 mmHg and gonioscopy revealing 180-degree contact and the presence of any optic nerve head changes. Data were collected at 2 weeks, 1, 3 and 6 months. Patients diagnosed with primary angle closure glaucoma, significant cataract and progression of visual field were included, and patients with chronic angle closure glaucoma, any prior ocular surgery, active uveitis, monoocular were excluded from the study. The outcomes were measured in terms of IOP, AGM, best corrected visual acuity, any complication and surgical success. This is a video showing after phacoemulsification, GSL was done with the cyclodialysis spatula. Move forward. Then goniotomy incision was moved forward. Then the goniotomy incision was given with MMBR blade and complete 360-degree trabeculectomy was performed in all PACG patients. Coming to results, data were analyzed using statistical software and with a mean difference of 8 mmHg at 5% level of significance using 80% power sample size was calculated. Coming to success criteria, complete success was defined by criteria when IOP less than or equal to 21 mmHg and more than 20% reduction without AGM. Criteria 2, IOP less than or equal to 18 mmHg and more than 30% reduction without AGM. Qualified success was defined achieving success with AGM, and the inability to meet the criteria for success or requiring any surgery were considered as failure. These are the various demographic characteristics of all PACG patients with baseline IOP of 21.13 mmHg and baseline AGM 1.95. IOP significantly decreased from 21.13 to 12.65, and there was a significant reduction of AGM from 1.95 to 0.17. 84% of IOP reduction was seen at 6 months with 86.9% AGM free. Best corrected visual acuity also improved. The complete success was 85.1% by criteria 1 and by criteria 2 70.7%. 1.2% required AC wash. Coming to discussion, there are various studies which show similar outcomes to a study. Limitations of a study were shorter duration of follow-up and small sample size. To conclude, combined CAD with phacoemulsification is safe and efficacious procedure in terms of IOP control, AGM reduction and good surgical success in patients with primary angle closure glaucoma.
So what is study published in AIOCMT3?
This study?
Yeah.
No.
So you would compare the outcome of CAT in angle closure. Have you compared any other mixed procedure in angle closure? Instead of CAT, KDB or BANG, have you compared with it?
So we are still collecting the data. We are yet to publish. So we have done KDB, Tanito in our institute. So we are yet to publish.
What about when you did the GSL along with the CAT procedure? How much percentage was hypermolicin in these patients?
So in some, so if we carefully perform GSL with cyclodialysis spatula, there will be no hyphema. If there is chronic past with chronic patients, if we do GSL, then hyphema can be removed.
So very good outcome actually compared with plain phaco cataract surgery, because cataract surgery does give an IOP reduction and angle closure, but when you combine with any mixed procedure, that's why I asked you, have you compared with BANG, KDB and CAT? So of course CAT gives better IOP control when you compare with KDB or BANG. So very nice study.
Very nice. And have you studied other literature regarding the same procedure in angle closure cases? Is there literature regarding the same?
Yes, sir.
Any other study?
Yes, sir. There are studies. There are 3 studies in which GAP was performed in PACG patients only. The surgical success was comparable to our study.
What was their follow-up? How long was their follow-up?
Sir, the first study was up to 12 months, Sharkari et al. 12 months, and the Sayed et al. was up to was on 6 months, and the third, the last study was also 6 months. Sir. So the Sharkari et al. has reported 12 months outcome. Yes, sir.
Are you going to, you're still going to
So we are collecting the 1-year follow-up and then we will
So
publish.
actually, in Indian data for all this mixed procedure, we have only 6 months follow-up. Most of the literature also says 6 months. So I think you all should continue this study so that your follow-up time increases and 1 year, 2 year data is collected to know the outcomes.
I think it's a very good study, and as Sir said, it needs a long-term follow-up to infer for the public, but then for us to infer.
Yes,
It's a very good study.
Thank you.
So next is Dr. Richa. She
By spawn versus injection trap study, trabeculectomy surgery. So no conflicts of interest and no financial disclosure. As we all know, glaucoma is the leading cause of irreversible blindness, and IOP is the only modifiable risk factor which we can lower to slow the disease progression. Trabeculectomy still holds the gold standard surgical modality for uncontrolled glaucoma. The challenges in trabeculectomy are functionality, that is the blade functionality depends on scarring. So antimetabolite use, which helps in delaying the wound healing by inhibiting fibroblasts and fibroblast proliferation and endothelial cell growth. The aim of our study is to compare the safety and efficacy of intraoperative sponge application versus intradermal injection during trap. The objectives were compare outcomes, complications, and safety. So it is a hospital-based prospective interventional study, and ethical approval was taken. The sample size was 122 patients, which were divided randomly into group A and group B for sponge and intradermal group. So the inclusion criteria were all patients diagnosed with primary and secondary glaucomas, patients with progressive glaucomatous damage despite IOP control, with medical therapy, and non-compliant patients to the medical therapy. We excluded patients less than 18 years old with no light perception and history of prior glaucoma surgery or any anti-metabolic use. So the preoperative preparation and glaucoma evaluation was done, written informed consent was taken. In the surgical procedure, as you can see in image 1, we are putting a sponge with a mitomycin C concentration of 0.4 mg per ml, which was kept for 2 minutes. And in group B, we injected 0.1 ml solution of mitomycin C, where we achieved a concentration of 0.02 mg per ml. The key steps of the surgery are as shown in the images. Post-operative follow-up was done on day 1, 7, 1 month, 3 months, and 6 months. IOP measurement and blood morphology were assessed for the success of surgery. The criteria for success was kept at IOP less than 18 mmHg or 20% or greater decrease in IOP from baseline, no need of anti-glaucoma medications, and no significant complications. The failure was defined as IOP more than 18 mmHg or less than 20% reduction from baseline, or IOP less than 5 mmHg on 2 visits after 3 months, and reoperation for further glaucoma IOP lowering. These are the post-operative images in sponge group and in the intradermal group. This chart shows demographic data of all the patients. So there was more prevalence of primary glaucoma in our area, so the patients were more of primary glaucoma. Post-operative IOP at 3 months, it showed borderline significance at 3 months, where the IOP lowering was more in group B, and the percentage reduction was also found borderline significant with 40% reduction rate in group B. When we compared blade morphology, group A had larger, diffuse and avascular with thinner blades with a failure rate of 22.95%, while group B has smaller, diffuse, mildly vascular and thicker blades with 19.67% of failure rate. These are the complications in blade-related complications in both the groups. The success rate was comparable in both groups, but no significant difference was seen. The post-operative IOP at key time points. Group A showed significant lower IOP on day 1, while Group B showed significant IOP reduction on 1 month and 3 month follow-up, while the 6 month follow-up showed no significant difference. So the key findings of our study were significant IOP reduction in both groups with a trend towards better IOP control in intradental group. Bleb-related complications were slightly lower in the intradental group, and these are the studies supporting our findings, Maheshwari et al. And Kandarkis. The complete success rate in primary glaucoma patients was 93.75%, while in group B it was 94.1%. In secondary glaucoma patient, group A showed 86% rate and group B showed 96.3%. So the bleb-related complications were lesser in intradental group, and intradental group had more favorable bleb characteristics. Limeta and Lietal are the supporting studies, and safety profile was comparable in both the studies. We conclude by saying intradental MMC injection is safer, equally effective alternative to sponge application with better long-term IOP control and fewer complications. Thank you.
So which sponges were used for this?
So the surgical sponges.
What is it called?
Sorry.
What are the name of the sponge what you use? They are not called a surgical sponge. There is a specific name for this sponge.
Yes.
Yeah, menstrual sponge. And what was the reason for the small size of your bleb in the intravenous group?
So the application of hydromycin was different. The area of application was more, and the concentration reaching the eye was definite, and it was lesser actually.
You mentioned the bleb size was smaller in the intravenous group,
Yes.
whereas it was wider in the
Wider.
sponge group. So what should be the reason for it? Was your technique correct? So you should know why it is smaller. If you know the reason, then you can improvise it. So why it was smaller? So whenever you do this injection, you are supposed to iron it out for a wider area of application so that the microbiome is spread to a wider area. If you do that, then you won't end up with a smaller bleb. Why the complications were high in the sponge and less in the intravenous group?
So as we can see, the concentration was more in the sponge group, while it was significantly lower in the intradental.
The concentration was 0.04 in the sponge group.
It's 0.4 and
Yeah, and here it was
0.0.
The diagnosis of Sturge-Weber syndrome is based on the presence of at least 2 to 3 manifestations in a classic triad leptomeningeal angioma, Gottman stain, and ocular abnormality. Aim of this study is to study clinical profile in Gottman stain patients and correlation with glaucoma secondary to Sturge-Weber syndrome in tertiary care center, Jharkhand. My study is prospective hospital-based observational study. Duration of the study was 2 years. It occurs in Rio Rims, Ranchi, Jharkhand. Sample size is 29% with pot minus stain and glaucoma secondary to Sturge-Weber syndrome. Inclusion criteria was pot minus stain on facial skin. Diagnosis with glaucoma is less than equal to 18 years. Exclusion criteria was family history of glaucoma, history of ocular surgery, ocular trauma. The study was conducted in adherence with tenets of Helsinki Declaration, and consent was obtained from the parents or legal guardians of all present. A detailed history of patients was recorded, including age, gender, ethnicity, clinical presentation, family history, and systemic and ocular characteristics. Ocular examination included dust-corrected visual acuity was measured by Snell's chart, IOP by Goldman apparition tonometer, slit lamp by microscopy performed under coral sedation, was carried out for NTA segment examination and fundus examination. Evaluation of choroidal hemangioma by B-scan ultrasonography. Glaucoma was diagnosed if at least 2 of the following criteria of childhood glaucoma research network were met. IOP on the corresponding side of pot minus stain was more than 21 mmHg, or if the IOP on the ipsilateral side of pot minus stain was higher than contralateral side by more than 6 mmHg. Corneal diameter enlargement. Cup disc ratio was more than 0.6, or asymmetry was more than 0.2 between the affected eye and contralateral eye. Results out of 29%, most of them was less than equal to 18 years were included, in which majority are males. In most of the cases, glaucoma is unilateral on the side of pot minus stain. Majority patients comes under less than equal to 4 years of the age. Most are male. Out of the 21% with unilateral facial pot minus stain, glaucoma occurred on the same side of pot minus stain. Among the patients with bilateral facial pot minus stain, only 2 were diagnosed with bilateral glaucoma. Majority are glaucoma and choroidal hemangioma. In between glaucomatous eye and unaffected eye, most of them increased IOP, corneal diameter, axial length, and CD ratio in the glaucomatous eye. These are some pictures which are collected during my study. Conclusion of my study: the eyes with glaucoma had higher IOP and larger axial length and CD ratio. Early diagnosis and treatment of glaucoma can help to improve visual outcome, as well as it is also important to early diagnosis and treatment of neural complications. Limitations of a study: firstly, small sample size; second, gonioscopy examination for 2 young patients were difficult; and lastly, the absence of cranial magnetic resonance imaging results for all patients prevent comprehensive assessment of intracranial lesions. Glaucoma presents in 30 to 70% of patients with Sturge-Weber syndrome. Of the systemic hamartosis, Sturge-Weber syndrome has the highest incidence of glaucoma. The incidence of glaucoma
increases when the port milestone involves the eyelid. When the glaucoma is present at birth, it is due to a malformation of MPH chamber angle, and the patient manifests typical signs of congenital glaucoma, including nystagmus and isometropia and amblyopia. When it presents later, it is usually secondary to elevated intrascleral venous pressure. Another mechanism of glaucoma is thought to be premature aging of trabecular network, which cause an early onset chronic open-angle glaucoma, changing in early adulthood. Medical therapy is the first line for the management of glaucoma that occurs in later life. These are the diagnosis.
What is the most significant part you take care of when you are treating glaucoma patient with tertiary symptoms, especially when you are doing surgical management? What are the most dreaded complications one can expect?
Uveal fusion syndrome.
Okay. So, how will you prevent that? What precautions will you take?
We will do first a sclerotomy and then trabeculectomy.
So, what is the reason that the glaucoma is more common on the side of the port wine stain?
It is due to elevated intrascleral venous pressure, and which is due to AV malformation.
So in literature, what is the percentage where you have bilateral glaucoma in such patients? In your study, you had 2 patients, right, out of the total. So what does literature say about it? Bilateral presentation of glaucoma in patients who have unilateral port stain.
So you examined your patient under oral sedation. What does that mean? You mentioned that?
It is. Sometimes most of the patients was less than 4 years or equal to 4 years of age. The patients was not cooperative. Then some oral sedation it will help us to examine.
Okay.
What you give for oral sedation? Basically, so what she's asking is, what do you mean by oral sedation? What medicine did you give for oral sedation? You are asking us or you are telling us? क्या दिया आपने?
You mentioned oral sedation, slit lamp examination under oral sedation. Usually what we do is in such a small study, we go for a general anesthesia and then we take the corneal diameters and do all of it. But under a light. So how do you do that? I just wanted to discuss
क्या आपने किया था या somebody else has done this? Somebody your consultants or your professors? So you must have seen how they do it, no? Oral sedation दिया था, IV दिया था, आपने बोला oral sedation दिया, तो OPD में किया था या एग्जामिनेशन OT में किया था?
We do help from pediatric.
So this procedure was done in the OPD or in the OT? In the OPD. So usually these procedures are done in the OT and the short sedation, IV sedation. Okay, so if you have done oral sedation, so it can be Finargan. You are right. The Finargan can be given so that the patient sleeps. But then you can't put a speculum and examine until when you give Finargan to a baby. Okay.
And also oral sedation, you can't do a slit lamp with a normal slit lamp. You have to use a handheld slit lamp. So be very careful while seeing the paper and you're writing a paper, right? So remember that.
Whenever you present anything, you should at least see the procedure, how it is being done. Okay. Thank you. The next presenter now, Ayush Punya. Yes. She is mostly. So any other speaker has come lately?
So the cataract surgery being the most common ophthalmic procedure worldwide, and trabeculectomy, the gold standard for surgical glaucoma management, both carry inherent risks to corneal endothelial cells. Phacoemulsification is now regarded as the preferred procedure for cataract removal. It may result in the death of corneal endothelial cells because of the ultrasonic energy that is being used during the process. Corneal edema has been correlated positively with intraoperative endothelial cell loss. And the most sensitive index of corneal endothelial dysfunction is coefficient of variation and its percentage of hexagonality for both units. The purpose of this study was to evaluate and compare pre-operative and post-operative changes in the specular microscopy following combined phacotrabeculotomy in group A and phacoemulsification in group B. Also, to determine correlation between the central corneal thickness measurements and its relation with the drop in intraocular pressure. Now coming on to the methods. This study was a prospective cross-sectional interventional study with 60 participants, which were divided in two groups of 30 individuals, visiting glaucoma clinic at ESI Hospital, New Delhi, for a duration of 15 months. In group A, patients with primary open-angle glaucoma with moderate to advanced glaucoma who were on more than 2 anti-glaucoma medications and IOP more than 21 mmHg prior to the surgery were assigned for phacotrabeculotomy. And in group B, patients with primary open-angle glaucoma with mild to moderate glaucoma who were on less than 2 anti-glaucoma medications and IOP less than 21 mmHg prior to the surgery were assigned for phacoemulsification. The central corneal thickness was measured by Tomei SP100 pachymeter and corneal endothelial morphology, which includes endothelial cell density, average cell area, coefficient of variation in the cell size, hexagonality, and standard deviation of mean cell area, were measured by NITEC CM530 non-contact specular microscope pre-operatively and post-operatively on the days 7 and 1 month and 3 months post-operatively. The male percentage of patients in group A was 46.7% and in group B 40%. Female percentage of patients were 53.3% in group A and 60% in group B. Now coming to the results, as shown here in the graph, the mean CCT among the two groups of the patients is shown. There was a significant increase in the central corneal thickness at 7 days and 1 month post-operatively in both the groups due to loss of corneal endothelial cells leading to corneal edema. Later on, the decrease in central corneal thickness was observed in 3 months post-operatively, which was more in group A than group B. Here the graph shows mean endothelial cell density among the two groups of the patients. A decrease in endothelial cell density of the group of cornea in 7 days, 1 month and 3 months post-operatively was among the patients in both the groups was seen. The graph shows mean coefficient of variance among the two groups of the patients, and the change in coefficient of variance was significantly higher in group B than group A at 7 days, 1 month and 3 months after the surgery. This graph shows a significant decrease in hexagonality of the cornea during 7 days, 1 month and 3 months post-operatively among the patients in group A. This graph shows IOP reduction was significantly higher in group A than group B at 7 days, 1 month and 3 months after the surgery. Now coming on to the discussion. Using specular biomicroscopy, we have analyzed the endothelial cell loss after phacotrabeculotomy and phacoemulsification with intraocular lens implantation in POHA and glaucoma suspect cases. As seen in our study, the preoperative endothelial cell density of both the groups were comparable and fell within the normal range, whereas postoperatively combined phacotrabeculotomy causes more endothelial cell damage than the phacoemulsification alone. The higher endothelial cell loss was noted in group A due to adjunctive use of vitamin C also. In group A, the patients who underwent combined phacotrabeculotomy, there was a significant increase in CCT at 7 days, 1 month due to significant loss of corneal endothelial cells leading to corneal edema in immediate postoperative period, whereas the decrease in CCT was observed on 3 months postoperatively. A significant increase in coefficient of variance, decrease in the endothelial cell density and hexagonality parameters of the cornea during 7 days, 1 month and 3 months postoperatively was seen. In group B, the patients who underwent phacoemulsification, there was a significant increase in central corneal thickness and coefficient of variance at 7 days, 1 month and 3 months post-op. A significant decrease in endothelial cell density and hexagonality parameters of the cornea during 7 days, 1 month and 3 months post-op period in patients of phacoemulsification were also seen.
Thank you. Just wanted to ask you, in both your groups there was significant cell loss, CCT increase.
There was more in group A as compared to
But why in group B you are endothelial cell loss? I mean, phaco procedure now we so see there is no endothelial cell loss in phaco procedures nowadays. Because if it was there, then phaco wouldn't have been a day-to-day procedure for everybody. Right? So there are studies which are compared with SICS, phaco. So there is insignificant cell loss in phaco, in normal phaco. We are not talking about brown cataract, complicated cataracts. So your techniques have to be improvised basically to reduce the endothelial cell loss, number one. Now, what you mentioned, mitomycin was used in phacotra when that has caused less endothelial cell loss.
It's more endothelial.
And yeah, there's a more endothelial cell loss. See, mitomycin is endothelial toxic only if the drug enters into the entry chamber. Topical application of mitomycin won't cause endothelial cell loss. So if that was the case, we wouldn't have been doing using mitomycin in any of our procedures. You got what I'm trying to say? So mitomycin is endothelial toxic only when it enters into the entry chamber. On topical application, it should not. And both the groups, all parameters, CCT, increased endothelial cell loss more. But in phacotrap it is high. I feel that sometimes, somewhere the technique, what you are using has to be improvised to reduce this. But I would have been more happy if your study had shown that phaco was all the endothelial parameters were normal and phacotrap were abnormal. Then this is already which is published in the literature.
Yes. So the increase was only at 7 days and 1 month. They returned back to normal at
1 month. Nowadays, after phaco, class prescriptions are given after 2 weeks.
Yes.
So your healing time also is more than this. Got it?
Just one more. What is the difference in the side effect profile of 5-fluorouracil as compared to mitomycin C? And why we are using more mitomycin C as compared to 5-fluorouracil?
What is the role, sir? What is the asking is to know what is the mechanism of mitomycin, how it works, where it works. Then you can answer why mitomycin is used and not why it is used.
That will also partially answer some of the other
Then I see the aim of your study.
Your homework is to, so all your presenters, okay? Whenever you present anything, make sure you at least know everything about the topic what you are presenting, so that it is not just to present, your knowledge will be gained.
I just want to point out that with the aim of this study, can you go back to the methods where you divided? Yeah. So this is not true randomization, right? So if you want to compare something, you can compare. Like can be compared to like. So in this case, yahi pe the bias is created. So you need to take it in account that whenever a study is created, yours is an interventional study, and you're trying to create true groups. But the two groups should be like. So here a bias is created. Apart from what sir has said, that phacoemulsification there is less loss and less, that is in your mind. But in the study itself there is a bias. Okay? So keep in mind.
Dr. Astika, Dr. Astika,
Anybody is there?
not there.
Other than us?
Good evening everyone. My topic for today is role of phacoemulsification as a treatment modality in acute angle closure glaucoma. The following subheadings will be included: introduction, purpose of the study, materials and methods, results, and discussion and conclusion. Glaucoma is a leading cause of irreversible blindness worldwide. Angle closure glaucoma is a variant of glaucoma originating from any deformity in the structural configuration of the eye. The iris comes in close proximity or adheres to the trabecular meshwork by appositional or synovial means. Such patients present with a shallow anterior chamber and more anteriorly placed lens. An acute attack of angle closure glaucoma is traditionally managed medically by intraocular pressure lowering agents. This is commonly followed by a peripheral iodotomy or a peripheral iodectomy, either surgical or by laser. The management aims to relieve the pupillary blockage and establish a new pathway for the drainage of aqueous humor. However, a successful peripheral iodectomy does not always lead to a satisfactory IOP control. Many international studies done also show that primary lens extraction with intraocular lens implantation not only resolves the acute attack of angle closure glaucoma but also leads to long-term IOP control. The purpose of the study. The objective of the current study was to evaluate the effect of primary phacoemulsification and IOL implantation on IOP, vision, anterior chamber depth, use of anti-glaucoma medications and angle opening in eyes with acute primary angle closure glaucoma and coexisting cataract. Materials and methods. It is a prospective, non-comparative observational study over a period of 1 year from July 2022 to 23. Total 30 eyes of 30 patients were included in the study. Inclusion criteria was symptoms like ocular pain, blurred vision, nausea, etc. Increase in IOP above 22 mm mercury, ciliary flush, mid-dilated pupil, corneal edema, either gender in the age group of 50 to 80 years. My exclusion criteria was secondary glaucoma, history of uveitis and ocular trauma. Patients were given first-line medical management for IOP control, which included topical and systemic agents. Pilocarpine discontinued 7 days prior to surgery. A routine 2.8 mm clear corneal phacoemulsification done in all patients with IOL implantation. Patients were then followed up the next day at 1 week, 1 month and 6 months post-operatively. Complete ocular examination performed at each visit. Gonioscopy, disc assessment, anterior chamber depth assessment and ocular biometry recorded at months 3 and 6. My results. Intraocular pressure, as seen, the mean IOP post-operatively decreased to 12.83 plus minus 3.13 mm of mercury, hence a 96.66% success in the study. In terms of visual acuity, the best corrected visual acuity increased from the pre-op value to post-op, that means from finger counting 1 meter to 624 to 680 to 69. Medications required pre-operatively, which was a mean 2.23 plus minus 0.77, decreased to post-operative 0.27 plus minus 0.52. Total 7 patients required post-operative medications, out of which 6 required only for the first post-operative week and 1 underwent further filtering surgery at the end of 6 months. Anterior chamber depth is significantly increased from 1.97 plus minus 0.13 to 3.08 plus minus 0.15 post-operatively. Discussion. The crystalline lens significantly contributes to the pathogenesis of angle-closure glaucoma. With increasing age, the thickening of the crystalline lens causes pupillary blockage due to the iridolenticular acquisition. Removing the crystalline lens would deepen the anterior chamber, relieve the pupillary block and widen the angle. It stands as the primary treatment method that will decrease, if not eliminate, the underlying anatomical predisposition to angle-closure glaucoma. Lens extraction hence prevents a viable option for achieving successful IOP management with lower associated risks compared to filtration surgery in patients of acute angle-closure glaucoma. It also aids in controlling the intraocular pressure even if peripheral anterior synecdoche has occurred. In such cases, the remaining open angle may compensate for the functional loss caused by the closed portions of the angle. Our results showed significantly reduced IOP, decreased use of anti-glaucoma medications and increased anterior chamber depth after phacoemulsification and IOL implantation in patients with acute primary angle-closure glaucoma. The results were consistent with previous similar studies and suggest that primary lens extraction can be considered as an alternative therapeutic option for medically uncontrolled acute primary angle-closure glaucoma. Hence, to conclude, main objective of the study, that is intraocular pressure, reduced significantly in all but one. Success of the study is 96.66% at the end of 6 months. Usage of anti-glaucoma medications decreased post-operatively. There was a deepening in the anterior chamber depth, hence proving the safety and efficacy of phacoemulsification as a treatment in acute angle-closure glaucoma patients. Thank you.
So your title itself. Your title itself you have mentioned as phacoemulsification in acute angle-closure glaucoma.
Yes.
So it can't be phacoemulsification. When we talk about phacoemulsification, we think it is cataract. So basically, you are talking about clear lens extraction. Am I right?
Yes, sir.
So your title has to be carried as clear lens extraction number 1. And of course, your study has got 96% reduction. That is very good. But clear lens extraction is not an established management for this disease. This procedure works well if certain criteria in angle closure are met. So which are these criteria in which you will get better results and clear lens extraction should be advocated? I mean, when will you advocate clear lens extraction in case of an angle closure glaucoma?
So actually, my study, the 30 patients which I chose had a significant rate of cataract also. I forgot to mention it.
But in your discussion, everywhere you have mentioned clear lens. So there is to contradict the statement. That's why I'm asking. So what will be the indication for lens extraction? Okay, for cataract extraction, forget about clear lens. Now patient has NS1 to 2 cataract.
Yes.
Okay, and you will take this treatment modality as a treatment for angle closure.
Yes.
So will you do it for all the patients or certain measurements you are going to do and if they are satisfied then only undergo this lens
So
extraction?
actually, this is not a first line therapy for acute angle closure patients. First line therapy is still medical management, surgical iridotomy. But
But it is
the
very-
anterior chamber depth
Yeah.
is very important in such patients. Suppose the lens is putting so much anterior pressure on the angle so that the depth is very, I don't know the
No,
exact
so
depth.
I'll tell you, basically what happens is lens vault.
Lens
This is
vault.
something called as lens vault. If there is a high lens vault, then
Yes.
if you take out the lens, the angle opens up and IOP reduces.
Yes.
So that is the only indication for clear lens extraction in case of angle closure when you have a high vault. Got it? Thank you.
What was the age of the patients that you selected?
51 to 80 years. Ma'am, they had cataract. I did not.
No, even in an age of 51 to 80, if you take out the clearance, doesn't matter, because if you take it in young patients, you will create trouble.
Yes.